Welcome everybody to today's Penn AI Tech webinar. Penn AI Tech is the Penn Artificial Intelligence and Technologies Collaboratory for Healthy Aging, an initiative funded by the National Institute on Aging. Today, we're very happy to have with us Dr. Anita Ho, who is a bioethicist with a unique combined academic training and experience in philosophy, clinical organizational ethics, public health, global health, and business. She's currently clinical professor at the Center for Applied Ethics at the University of British Columbia, associate professor at the UCSF Bioethics Program, and vice president of ethics for CommonSpirit Health in California. An elected fellow of the Hastings Center and an international scholar of more than 90 publications, Dr. Ho's current research focuses on ethical dimensions of utilizing artificial intelligence in healthcare delivery, research ethics, supportive decision-making in healthcare, and end-of-life care issues. She's particularly interested in systemic and social justice issues arising in the use of AI in healthcare settings. Her recent book, Live Like Nobody's Watching, Relational Autonomy in the Age of Artificial Intelligence Health Monitoring, was published by Oxford University Press in May 2023. We're very happy to have Anita with us today. I want to remind our attendees that if you have questions during her talk, you can use the Q&A feature. And after the talk, we'll have a chance for Q&A and go over some of these questions and hopefully have a lively discussion. So with that, Dr. Ho, thank you again for joining us, and I'll hand it over to you.
Thank you. Good afternoon, everyone on the East Coast, especially for those who are in Philadelphia. I'm just glad that I'm not between you and the Eagles parade tomorrow. Congratulations on the Super Bowl win, since I'm from San Francisco, which we lost to the Chiefs a few years ago, or just last year. And so even more of a congratulations to you all. And also thank you so much for the kind introduction and the opportunity to be part of this. Let me share my screen. And so I want to make sure that you're able to see what I have got here. May I just do a check to make sure that you are able to see?
Yes.
Great, thank you. Thank you again for the opportunity to be part of the Penn AI Tech webinar series. And for most of my work in bioethics and AI ethics, I really think about ethical issues as multi-layer and interconnecting matters. And that will also frame my discussion today regarding the ethics of implementing AI home health monitoring for older adults. And with AI, we often think about the interconnectedness of multimodal data. But before I dive into the ethics around that, I want to start with a land acknowledgement and appreciation of our interconnectedness. Having lived and worked in different continents and environments, I really appreciate the interdependencies of all lives. And this painting titled Our Lives Are in the Land by Christy Belcourt, who is a Métis Canadian artist, this painting really speaks to me. A few years after this painting came out, Belcourt said, "The plants are teachers. They're connected to each other and all other spiritual beings through the sacredness of life. When I remember who I am, a human being connected to all of life, I remember also that I am loved by the spirit world and our ancestors. And when I remember this, I remember to respect even the smallest of things." As a dual Canadian and American citizen who was born and raised in a former British colony, I'm always mindful of how historical and structural context matters to how we make meanings about health and aging, our interdependency in providing and receiving care, and who owns and should have access to our personal and health data. As a settler of this land, I would like to express my gratitude to the Indigenous peoples who have been caring for the lands that I'm currently on. Today, I'm joining this seminar from Santa Rosa, California, which is the homeland of the Coast Miwok and Pomo peoples. So it seems that we hear about AI health ideas or technologies every day, or about how using multimodal data and advanced analytics can provide more efficient and personalized care for older adults. And with shifting social, economic, and regulatory perspectives around AI, we're now at what I would call like a socio-technological juncture. A couple years ago, I wrote in my book that you can see on the right about how our increasing optimism that AI can solve a lot if not all of our problems, or what some may call AI solutionism. This may really change the societal and individual expectations regarding technological power and our healthcare practices. This may include expectations around when and how we should use predictive analytics in healthcare, how much health risk people should be allowed to accept, how we should define personal and data privacy, what self-monitoring responsibilities we have, as well as personal and professional care relationships. I analyzed these intersecting issues using the lens of relational autonomy to examine how expanding datafication of embodied experiences and presumed objectivity of algorithmic predictions may restructure power relations. And depending on how we develop data and technological practices, we may enhance or compromise people's ability to exercise their agency regarding how they would like to monitor and manage their health. So for today, my talk is partly informed by my book chapter on AI home health monitoring and my recent embedded ethics study in Vancouver, Canada, on using computer vision for identifying and predicting progressions of Parkinson's disease. And using the lens of relational autonomy, I will focus today on how evolving AI health monitoring technologies and practices may affect therapeutic and other power relations. And to address these issues, I will explore the multi-level ethical considerations for developing and implementing AI health monitoring technologies. And I'm sure that we have all heard about various reasons why we really need to have a paradigm shift when it comes to monitoring older adults' health progressions. Longer life expectancy in the US and across the globe means that people will have more opportunities and more time to develop impairments and chronic conditions, which may affect their daily activities and functioning. Older adults who may experience these conditions nonetheless want to age in place, independently, but also in relationships. They want to live in the community, supported by loved ones, rather than in institutions surrounded by strangers in different shifts. Degenerative conditions in the aging population require substantial monitoring and management that can be very labor intensive. Especially with demographic shift, we now have smaller family sizes and many women working professionally in addition to continuing to provide the majority of caregiving duties, sometimes intergenerational or multi-generational caregiving duties. And there is also a shortage of medical and home health professionals. So many health systems, older adults, and informal caregivers are also trying to find other ways to support care delivery. We now also see shifting regulatory and funding landscape of healthcare delivery and AI developments. I mean, in many ways, things are changing so quickly that sometimes even I find it really hard to keep up. But these things are really evolving in relation to how older adults and health systems may now detect, monitor, or prevent disease progression. On the regulatory side, some of you probably already know that the Biden era executive order for safe, secure, and trustworthy development and use of AI has recently been replaced with removing barriers to American leadership in AI by the new administration. And as international competition heats up, and we have been hearing a lot more about generative AI in the last few weeks, just this week at a global summit in Paris, the US has said that it will not sign an international agreement on AI that pledges an open, inclusive, and ethical approach to technologies development, because it worries that too much regulation and the global governance may, quote, kill a transformative industry that is just starting to take off. So with that backdrop in mind, we will likely continue to see lots of momentum in expanding AI integration in home health monitoring or for older adults. But there may also be more questions in terms of how we would be able to do them safely and ethically. These technologies may, or different practices may now include going from post-acute remote monitoring programs to direct-to-consumer home health monitoring that aim at improving patient care, patient outcome, lowering readmission rates, lowering or shortening hospital length of stay, and helping older adults to stay at home for as long and as safely as possible. Some of you may recall that in November 2020, in the height of the first wave of the COVID pandemic, and before vaccines were available, The CMS issued a temporary waiver that has allowed Medicare certified facilities to provide a wide range of hospital-level acute care services in patients' homes. As of the end of November 2024, more than 370 healthcare facilities across 39 states have been approved for the waiver. Many are really hoping to see that these hospital at-home programs can continue and perhaps even expand, as they may have benefits for older adults in helping them to be cared for in the familiar home environment, which may also help to decrease delirium, fall risk, hospital-acquired infections, and so on. And with the aging population, there's also increasing demand for ongoing home health and support for older adults beyond acute care setting, to hopefully help to support people with chronic and degenerative conditions. But the challenge is that all these programs require extensive human resource. And unless, for the CMS waiver, unless there is further extension, the waiver will end at the end of next month. And home health agencies, for the chronic condition kind of monitoring, on average deny about 60 to 70% of eligible patients because they don't have enough human resources. So many older adults, informal caregivers, and even long-term care facilities are really trying to consider whether there may be various kinds of gerund technologies that they can use to help to support health monitoring, track older adults' vital signs, medication adherence, predict fall risk, et cetera, et cetera. So how may AI help then in providing home health monitoring, especially in the face of shortage of human resources? So they may help to, for example, parse through lots of different clinical data to help risk stratify patients to determine who may be the best candidates for home hospital programs or home health, especially knowing that not everyone who may benefit from these programs may be able to access due to shortage. AI may also be able to help with administrative tasks, such as using generative AI to assist with completion of assessment forms by pulling progress notes, discharge notes, and so on, to help people who may be doing the intake assessment. AI may also be able to help to harmonize multimodal data to help to customize monitoring based on each patient's clinical presentation, social support, or demographic factors. And once deployed, AI may be able to help to identify and alert various health risks and perhaps recommend professional visits if and only if it's necessary. So on the right here, you can see a picture of home health monitoring that can use different modalities to track the person's diet, what time they're eating, how much they're eating, how much they're resting, are they taking the medication, or are they also having unsteady footsteps that may indicate alerts, indicate risk that may warrant alerts, for example, to informal caregivers or even to professional caregivers. So there are definitely very high hopes among technologists and health systems that the more multimodal data that we can collect, analyze, and use, the better we can develop personalized care plans for older adults that can be delivered remotely. As you can see in this picture, which is very busy, partly I think because there are so many possible opportunities for the use of AI in home health monitoring. This may include tracking vital signs with wearable sensors, evaluating the home environment the older adults are living in and carrying out their daily activities with ambient sensors and computer vision technologies, or using assistive robots to help provide support and track communication activities and trends. Certainly, there are lots of unmet needs and exciting opportunities as data sources and computing capabilities continue to expand. But for older adults, especially people who may have lower levels of comfort with the rapidly evolving technologies, there may also be questions of intended users' readiness. Older adults may worry about the implications of whether or how AI home health monitoring may affect their social and therapeutic relationships, as well as their relationships to their living quarters. In fact, family caregivers, who are often women, may also have questions of how the deployment of these technologies may affect their caregiving role. So we need to consider various ethical dimensions of developing and implementing these technologies. And as I mentioned earlier, our research team in Vancouver conducted an embedded study, ethics study on how people living with Parkinson's may think about the use of computer vision to continuously monitor the disease progression. And it was actually quite interesting to see how the participants themselves also thought that institutions and health systems need to think about different levels of ethical concerns as they develop and implement these technologies in the name of better patient care. So we can break these layers down to what I consider to be micro, meso, and macro levels in thinking through how to develop and deploy various AI-powered systems ethically, recognizing that these are intersecting layers that require system thinking and that we have to go beyond the linear assumptions. So at the individual level, we can really think about ethical considerations around particular devices or models that we are trying to deploy and to help with monitoring the older adults. For example, do we have enough data to show that the model is actually accurate for the monitored older adults? Keeping in mind that data used in training algorithms may not always be diverse and representative of the intended users. And do we have enough safety evaluation to show that the model or device won't cause more harm and that it is aligned with the user's desired privacy protection and that there are clear parameters on who can access the individual data? And interestingly, going back to the Parkinson's study I mentioned earlier, not all the participants agreed on whether or how much the family caregivers should have access to the data, let alone companies that may be developing these AI models. And this may be particularly concerning when an AI model is not considered a medical device, because in those cases, they're generally not regulated, even if it may be used in the healthcare setting or for health improvement purposes. So this really gets to the consent issue also at the individual level. Can patients, families, or providers really understand the operations of these devices or models or say no to being monitored by AI-powered devices? This may be especially a question for people when they're thinking about how the use of, for example, hospital at-home programs or the use of AI health monitoring at home may be more operational decisions that may be tied to discharge decisions and funding determinations. Often when it is an operational decision that we don't ask patients for individual consent. So there may be the ethical dimensions in terms of how do we, ethically speaking, utilize these resources when we may not actually have older adults explicit consent, when they may also have various levels of discomfort with the technologies. And even though many technologists and health systems would say that users can consent, but they often actually don't have the power to refuse if there aren't other viable health monitoring options. So I think that there are certainly questions about how much control also that monitored adults can have over the AI-powered system and how the outputs are being used. So even if they cannot say no to using the system, can they say no to, or can they at least have some control in terms of when they want to be monitored and not monitored? On the right here, you can see a picture of a care robot called Dory. This robot has sensing system for monitoring older adults at home. It was developed by a research team in Korea. This CareBot provides focal service areas of cognitive support, emotional support, physical activity support, medication management, and caregiver management. Interestingly, when the research team conducted focus groups with clinicians and professional caregivers, they found that these groups have different perspectives on whether older adults should be allowed to turn off the monitoring or alerts. And this may have even more implications when we're not just looking at a single episode of monitoring, but continuous monitoring of different types of activities in people's home setting. As some monitored older adults may also have or will experience cognitive decline over time, I think that there are also important ethical questions of whether they have real opportunities to consent or refuse ongoing monitoring as time goes on, especially given the vast amount and type of information that may be collected and merged regarding people's activities. So still at the individual level, There are also interpersonal and relational considerations, especially since family or other informal caregivers may be involved in assisting with technology use or may be tasked with or authorized to receive alerts. Interestingly, in the Parkinson's study I mentioned, some of our participants pondered whether using AI monitoring may actually affect how much their children will visit them. Some of them were saying that they were worried that if things look good on the AI output, maybe the children would think that then their parents are okay and that they don't need to visit them as much. And so if that's the case, then it may exacerbate social isolation for some older adults who may already not have a lot of opportunities for visits. There are also ethical concerns around how different stakeholders may have different privacy expectations, risk tolerance, or desires regarding ongoing monitoring. And this may depend also on whether the device may capture data about just the monitored adults versus other people who may be providing care. So for example, some devices may also track the response time that a caregiver may have in terms of coming back or responding to an alert that has been sent out by the system. It may also track how a caregiver may be providing care in response to the alert as well. So it may raise other kinds of questions in terms of whether privacy is only for the monitored adults or other people as well. And while there is a general assumption that older adults would like to receive care at home rather than in an institutional setting, which may very well be true, there are also questions of how the monitoring devices may alter different parties' relationship to each other and to their home environment. And as technology developers mostly be thinking about the older adult patients, there are also micro-justice implementation considerations in terms of whether we care equally about the interests of all these other affected stakeholders, especially if they may be monitored. We also need to think about how power relations between older adults and family caregivers may change with the use of these technologies. For example, some studies have shown that adult children are more risk averse than their older adult parents when it comes to undetected or unmonitored risk at home. So many adult children are a lot more ready or willing to use the monitoring for their parents than their parents themselves. Sorry that I don't know why that my dot points actually showed up as question marks on the screen here. So there are also more of the organizational or professional level considerations in implementing home health monitoring. Intersecting with my earlier comments, do we know that we will be capturing high value data that have good clinical values versus information that we have that may be more noise and distracting us from the real clinical situation? For example, will the use of AI home health monitoring and the data collected truly help to promote what some people may call the quintuple aims of improving patient and outcomes? So in relation to the Institute of Healthcare improvement in really thinking about what would actually be value-based healthcare, we may want to ask questions in relation to whether the particular model that we are using will actually improve patient and population health outcomes, reduce costs, enhance caregiver experience, and also promote equity. And in balancing these different aims, we also need to think about whether the use of AI home health monitoring benefits to organization because of human or other kinds of financial implications versus truly promoting the priorities of the older adults. There are also questions of whether the implementation plan is inclusive or equitable. So for example, we may want to ask questions in terms of whether this is incorporating cultural differences regarding intergenerational privacy, and whether there may be appropriate evaluation and appeal process, especially in the early days of adopting these technologies. One thing that has also come up across the country as many health systems try to speed up the AI technology use is how much upfront cost it might take in investing in these technologies and retraining the workforce to use these technologies. And because the use of the technology is often partly a response to the lack of human resources, some may ask also whether healthcare systems should actually be investing more money in hiring more people to provide health monitoring rather than outsourcing these responsibilities or care work to machines. So this may be particularly important to consider when increasing datafication and automated predictions for older adults who, especially if they prefer in-person monitoring, may risk depersonalization and dehumanization in their monitoring process, especially if the use of AI is reducing therapeutic and environmental relationships to instrumental practices. So people may have their own symbolic and emotional attachment to where they live and their care relationship, particularly with family caregivers. But when we are now using technologies, we have to be careful whether the technology is now changing the way that people relate to these environments and those care relationships. And I mentioned earlier that some older adults may worry that AI can decrease family visits, but the same also can be said about access to professional interactions. Some of our participants living with Parkinson's, for example, said that they worry that if the AI output says that they're actually doing well, in Canada, often you only have one formal consultation with your neurologist, that they worry that maybe they would even lose access into seeing that neurologist. And having generative AI to help with assessment that I mentioned earlier may very much be efficient with intake and workflow, but often, especially for older adults who may lack other kinds of social interaction, this in-person intake interaction may actually be something that is really desired by the older adults. And in fact, often having the in-person visit, laying eyes on the person may actually also be really helpful in giving other kinds of information that may otherwise not be captured by the models. So we really need to think about how using these technologies may change the in-person interaction as well. And at the more social or system level, there are also questions of fairness and non-discrimination. And this may be also about whether there is an assumption about age, that because people are at older age, that older adults as the category should be subjected to continuous monitoring and predictive analysis. So there may be concerns about how some of the implementation processes that make these kinds of age assumptions, it can be a form of technological paternalism that may be discriminatory, especially if other people not the older adults themselves, are predefining what would be acceptable risk tolerance level, what acceptable privacy boundaries that may be for a confidentiality limit, and what caregiving modality is most appropriate. And so especially if we are also predetermining how older adults must perform self-care and self-monitoring for their own good, there may be questions in terms of whether there may be this underlying sense of paternalism based on age. And this may be particularly concerning with increasing datafication of older adults' subjective embodied experience and the assumption that objective algorithms may provide more answers and solutions than older adults' own testimony about their embodied experience, their preferences, and their desires. So depending on how the AI model is developed and implemented, and how we may or may not be incorporating the voices and desires by the older adults, there may also be questions of whether implementation of these technologies could be a form of epistemic injustice if these older adults' voices and concerns are left out. So these broader social issues, I think, also intersect with the reality that there is increasing commercialization of personal and health data in AI development. So the promotion of AI home health monitoring needs to be understood within the broader institutional and corporate structures of power. The study I mentioned with people living with Parkinson's, maybe partly because this is done in Canada, which is a publicly funded healthcare system. Most of the participants said that they would be very happy or at least willing to share their data with research universities and so on, but that they were more concerned about how now companies that are involved in developing these technologies may at some point start to use and own the data, and which many people were not really willing to do. even for de-identified data. So this may really raise broader, I think, social and structural questions in terms of how do we reconcile people's concerns about their individual data and the increasing commercialization of data practices. And this is especially important, I think, because the increasing line blurring between private and health information, especially when now a lot more information with home health monitoring is collected outside of the formal clinical setting. This may gradually reframe what it means for somebody to be a patient whose activities and information can be monitored on an ongoing basis and how that data can be shared. And as I mentioned earlier, many older adults are still not familiar with this rapidly evolving data practice or AI practice. So the quick deployment of these technologies when monitored users are not ready yet may reinforce the social and digital divide as well. So again, these micro, meso, and macro ethical issues intersect. And as we continue to develop and implement more and more AI home health monitoring models, we also need to be aware of how continuous monitoring is part of a moralizing framework of self-regulation and self-improvement in healthy aging. So I think in general, of course, generally speaking, promotion of healthy aging is a laudable goal, but sometimes older adults may also feel that they are being pressured into adopting a certain notion of what healthy aging means. This may be especially because older adults are increasingly expected to, so to speak, do their part and be responsible for their own health. Sometimes this is framed in language about empowerment, that you are engaged, you are empowered, and to take control over your own health, even though there may be many other social and environmental determinants of health that are contributing to older adults' ability to flourish, ability to maintain good health, and actually have the right kind of monitoring that they would like. So as we expand offerings of AI-powered home health monitoring, we need to be aware of how regulatory gaps also means that even ethically responsible health systems may not have access to transparent data sources and validation processes for proprietary models. So this goes back to my earlier comments about commercialization of these data practices as well. This may make it very difficult for health systems to ascertain the safety and equitable health benefits before they can decide whether to invest in piloting or implementing a particular health monitoring model, especially because there may also be uncertainty around liability questions due to the lack of clear regulations. And as people's insurance status and social support availability may also have impact on people's options for health monitoring, this brings back to my lens of relational autonomy, to ask questions in terms of whether older adults truly have autonomy to make health monitoring decisions that fit their priorities and goals as we are entering into a rapidly evolving time of increasing use of technologies or expectations of technologies being used to monitor people's health. So, as I mentioned earlier, we do need to have a major paradigm shift in how people are being monitored for their health progression. But such rapid change also requires trustworthy practices. So some recommendations as we continue to develop and implement home health monitoring models may include having standardized and transparent evaluation frameworks to ensure the quality and outcomes of AI models before deployment. And in developing AI home health monitoring models, we also need to have deep understanding in terms of the context of how these technologies may be used. For example, what information does the monitored older adult really wants to use and wants to be shared, and with whom? So, for example, even in our study with the Parkinson's on Parkinson's disease, some of our participants talked about how they may want certain information to be shared with the family members, but not others. So, for example, some of them said that I may be okay with the information being shared if I actually fell, but not only if I'm unsteady on my feet, right? And some of them also wanted to make sure that they have some control over whether they should be monitored in the bathroom or a bedroom or in more intimate spaces, even though they acknowledge that information about how much time it takes them to get in and out of the bathtub or the shower and so on may be helpful in predicting their disease progression. Older adults may have different levels of desired engagement with the technologies and continuous monitoring. And it was interesting with the Parkinson's study because some of the participants recognized that as their condition progresses, their cognitive ability may decline, and those may also be times when the risk level may also increase. And so there are also questions in relation to how do we reconcile that when people are at times when their ability to consent or withdraw consent may decline, that they may also be at a higher, at a time when actually the use of these monitoring technologies may actually be more beneficial. So how do we balance the respect for people's autonomy versus their well-being? So some people may also then suggest, and actually the computer vision program that we were looking at is partly trying to achieve this as well, that technologies that can convert data from more embarrassing situations or more intimate kind of information, if we can convert that into more non-sensitive information that can be seen by caregivers, that may be more acceptable to older adults, especially when they already feel very vulnerable, and sometimes they already feel that other people have more power over how they can use or see their information. And this may also be important to make sure that as we are developing and trying to think about implementation plans of these technologies, that we are incorporating the perspectives of all stakeholders to prevent any clinical and ethical risk, especially if we don't have regulations to help to support those kinds of monitoring as well. So even as we use AI to assist health monitoring and caregiving, we still need to safeguard the human dimension in the more, I guess, perhaps more AI-assisted or even AI-driven care. We need to have clear design goals that would incorporate also individual goals, as well as having human values being incorporated into the development and deployment plan. Certainly, many have argued of making sure that we are developing human-centric AI. But part of the question I think is actually very important in thinking about generating technology is which humans are we talking about when we talk about human-centric AI? Even with the development of Dory, that little bear that I was showing you earlier, from the study, I thought it was quite interesting here. Part of the study in the article, they said that, quote, "We assume that for the development of this care robot, the individual goals of older adults will be the same as their families, and thus matters of shared decision-making or intervention are not considered in the study," end quote. Now, this may be because the study was being done in Korea, and then there may be more cultural assumptions in terms of alignment of older adults and families' shared goals. But that may not be true for some families or some individuals. So there may be questions in relation to how, when we are developing these technologies, when we are talking about human-centric AI, whether we are centering the older adults who may be monitored versus those who may try to use these tools to help monitor the older adults in assisting their own caregiving work. Certainly, those perspectives are very valid and important in integrating into the development and implementation plan, but we definitely need to make sure that we are not forgetting the older adults who are being monitored, which actually in some ways is why sometimes even when I think about the word users, when we talk about the users, I often think, who are the users? The older adults who are being monitored are often not the ones who are in control in terms of the setting or using them. Very often, they're the ones subjected to the monitoring without very much say in terms of how it is being done. So with that in mind, we also need to promote older adults' technological literacy so that they can understand the functions, the purpose, the risk and benefits of these technologies to help to fill ethical gaps as we are planning various kinds of implementation. We may want to ask, for example, whether even in the lack of having regulations to have nutritional labels for AI monitoring for older adults. Some of you probably have seen different types of nutritional labels for AI to really show what kind of model this is, what the base model might have been, what may be the different kinds of data being used and to train the models. Are humans in the loop? How are data being retained, and so on? So in relation to thinking about AI for older adult health monitoring, we may also even want to ask, how may the older adults be involved in the development or implementation plan of these technologies, and to help us to see whether the right kinds of stakeholders have really been involved in this whole process. So in closing, I think that we need to recenter the older adults throughout the whole AI life cycle as we think about what types of AI health monitoring, particularly home health monitoring, would be most beneficial to individuals who are subjected to that monitoring. We need to have deliberative processes with prospective older adult users and their caregivers to really understand their priority goals and the potential impact of algorithmic outputs, especially given that monitoring will be implemented in what is traditionally considered to be a private sanctuary for residents in that space. I also work in clinical ethics, and one of the things that often comes up, whether it's with older adults or other patient populations, is that very often we can give recommendations to patients in relation to the discharge plans. And one thing that we are very well aware of is that once patients go home, whether they actually follow our recommendations or not is completely up to them. We don't actually have the control over what they can or cannot do. We can hope for the best, and especially if we have more trusting relationships and the right kind of support, that we usually will see better uptake. But we don't actually get to control what they do after they get home. With the use of AI home health monitoring, especially with continuous home health monitoring, we may now actually be shifting that. And so that people who may think that they have more autonomy in their own space, in their own private sanctuary, may now be losing some of that. How we as a health system or as healthcare providers may be thinking about our risk tolerance may or may not be the same as the older adults. They may value their privacy differently compared to informal caregivers and formal caregivers. So we need to have deep understanding of not just how the particular AI model works at the micro level, but also think about that in terms of the broader macro development and implementation context. So that even in the absence of clear regulations, we can help to create appropriate governance structures, perhaps at our own hospital or individual health system level, to ensure that when we are researching in and developing AI models, that we have the right goals in mind, we have the right data to make sure that we have inclusive and equitable ways of actually using the information and the models, and the right response throughout the development and implementation cycle in evaluating and responding to results, especially if we realize that some of these models may not work as well as we have wanted, or if the older adults may have concerns in terms of how we're using the information in their care. So on that, thank you. And I look forward to your questions or comments. Oh, sorry, I think I realized I just forgot to advance my slides there. So I'll leave my slide to this one here. You can see that. Thank you.
Thank you so much for this wonderful presentation. Just to remind our attendees that you can post your questions using the Q&A feature. I think we already have some, so I'll ask the first one, which is actually from Lily Liu, who is one of the caregiver stakeholder engagement core participants from the Johns Hopkins Collaboratory. And the question is about translation of consent forms. How can we all, clinicians, researchers, patients, families, and so forth, agree upon and share a vetted standardized glossary of terms related to AI and data monitoring so that everybody's using the same terminology in consent forms, especially when distributed to non-English reading patients and their carers?
Thank you for that question. That's actually a really interesting question. I think an important one as well. Uh, I have to acknowledge that the first thought that came to my mind was that, well, we can use AI to do that too, right? And that with generative AI, many health systems are really trying to use large language models to see whether we can actually translate consent forms into different languages. One thing that I would also point out, as you know, the participant mentioned about, do we have standardized terminology? But also, I think that when we talk about standardized terminology, it cannot just be standardized in terms of the technical aspects of the models or implementation. When we are talking about standardization, we also have to make sure that we're not losing the cultural aspect of it. Partly because there may be different cultures or different cultural implications or assumptions in relation to how people think about privacy, how they think about use of technologies in their homes, how they may or may not want families to be involved in collecting the information and getting the information. So maybe we need to have standardized terminology, but at the same time, make sure that these translated consent forms are also culturally appropriate.
Great. There is another question about whether there are specific conditions, maybe falls, medication management, or exercise, that seem to be more universally embraced by older adults when it comes to using digital monitoring technologies, or do we still need to determine those individually or based on different contexts?
I think that's a good question, and there is some more, generalized in terms of like on average that people seem to be more accepting certain types of monitoring than others. In terms of monitoring in private spaces, there is more resistance to that. And there, in fact, in many ways, there is even more agreement of resistance to that in terms of older adults and also caregivers, informal and informal caregivers. What they sometimes disagree on is whether they should be allowed to turn off the monitoring or turn off the alerts. So with medication alerts, there is more disagreement, for example, in terms of whether older adults or any users or targeted users can turn off the alerts. Like if you're trying to remind the person to take the medication 3 times already and they are not doing it, can that just be shut off at that point, rather than ongoing pressuring of the person to do that. Fall, I mentioned earlier, like with the Parkinson's patients, for example, they said that while they do actually really appreciate fall risk and being detected and predicted, but they don't necessarily actually want that information to be shared with the family. They only want adverse events to be reported and shared rather than just the risk. They're more willing to share the risk information with the healthcare provider because for diagnostic and care plan purposes, but they don't want the family members to be more worried or perhaps would be, getting on their case in terms of what they should or shouldn't be allowed to do.
Great. I think we have a question that may be more in the Canadian context. The question is if the Office of the Information and Privacy Commissioner is consulted for review of AI technologies.
Good question. So depending on how this is actually being developed, and sometimes it may be being reviewed by even research ethics boards. So again, sometimes when it is about an operational decisions, and I think this is the part when I think is more problematic, maybe a little too strong a word, but more concerning, because when it is an operational decision, then generally how you're operating, how your hospital system, your health system use information may apply. And that, of course, individually identifiable information, certainly there would be privacy considerations, but in terms of secondary use of data for de-identified information, it's not always clear whether that would be protected under privacy provisions. And this is particularly the case in the US, that often, for example, the research ethics board won't even look at studies of using secondary data, even though with AI, there may be more and more concerns that when you're merging so many different types of information, that you would have a way to identify people eventually.
The next question is ask you to talk about what you think is the future of AI home monitoring. what it will look like and what it should look like in 3 to 5 years?
Great question. And so remember the picture that I was showing earlier, that was a very, very busy slide with all the different kinds of technologies. I do see it in some ways that may be the case. Whether I think that would be the most helpful and actually clinically beneficial or not, I think remains to be seen, right? So of course, we often would hear anecdotal information that people say, oh my gosh, it was so good that my smartphone had a way to track my heart rate. And so that I didn't even realize I had AFib until after I had an episode. And then it turns out that I have had this all along. And that may be the case, but I think that there are certainly questions in terms of whether sometimes when you have continuous tracking of information, there are often going to be blips. And for worried wells, when we have home health monitoring being tracking so many different kinds of individual personal activities that are now being framed in terms of health and healthcare, then people may be actually now giving more and more information of themselves, even when some of them may not really be directly related to healthcare. And I do think, and I didn't have time to go through this in more details, but that there may also be now, not even just in relation to home health monitoring, from the macro perspective, we also need to think about home health monitoring in a much broader surveillance culture, right? Everything that we are doing is now being tracked, being collected, and it often in the name of providing us with more efficiency, convenience, and well-being. So going back to the question about home health monitoring, I think that people probably would now be tracking more and more of their life because there is this promotional lens of how this is going to be actually helping you to be healthier. Even though if we learn anything about direct-to-consumer genetic testing as well, sometimes more tracking and more information may actually have more harm for those who may be so-called worried wells.
We have a question whether you think it's ethical to offer rewards like money or other remuneration for cooperation with monitoring when the person is low income.
Well, the disclaimer that I do not sign up for my employer's wellness programs. And so partly because I think that I can understand why corporations would want to actually have that information. But there are studies that also show, especially for smaller companies, depending on what you're tracking, you may actually be able to find out, for example, who is trying to get pregnant, who did not carry out a pregnancy, and so on and so forth, right? So if you have smaller companies and if you have people of a certain childbearing age, for example, and then you are giving them wellness devices and that allow them to track their ovulation, their diet, their exercise, to many different kinds of things. And then you can use that information to so-called plan your human resources. I think that, even though it's in the name of wellness for and convenience for employees, I think certainly, especially now in a much more politically charged environment, that there are lots of questions in relation to people's reproductive privacy and other forms of privacy as well. I do think that the incentive is certainly going to be even more attractive to people who may be of lower income, which also means that sometimes we may be putting more disproportionate burden of data involvement of people who may otherwise have less options to begin with.
Another question is, what do you think should be the optimal response time for sending health alerts to older adults? And what metrics should we consider when designing a system that balances their autonomy with their well-being?
I don't have an easy or simple answer in terms of what would be the best response time. I think that alerts should be sent to people who actually can act and make a difference in terms of the clinical outcome of the person. Because sometimes if you are sending too many alerts, people can also get alert fatigue, right? And so we have learned that not just in terms of older adults, but even in ICU settings or other kinds of medical settings. So the right kind of alert is one that actually people can respond to and that can actually make a clinical difference. Otherwise, we may be just having too many different types of alerts, especially for older adults who may not really be used to these kinds of alerts. They may also be confused given, depending on the hearing, depending on their vision, that sometimes the alerts may actually not be really promoting their well-being. So who can actually act, how can they act, may really determine in a more individualized way of thinking about how do we determine what would be the optimal alert delivery.
We have a question that's related to monitoring, perhaps more personal. If you could monitor your own family, at what point would you consider it is a point too far and would stop seeking that type of data?
I recently wrote a blog post about monitoring my mom, because my mom has been quite anxious and forgetful. And then one of my friends joked with me about how I should start monitoring her. And that, has been very tempting to me, partly because I live very far from where my mom is, and I talk to her every single day, but I don't actually get to see her as often as I would like. But I have to be true to my own word in terms of thinking about people's privacy and well-being. And I do think that people, when they are capable, they should be allowed to at least interpret what they think acceptable risk level might be. That may be different than my acceptable risk level. But when I one time did a slightly different talk in terms of AI monitoring, and asked the audience members, how many of you would be willing to use this on your parents or older family members? And most of them had their hand up. And then I asked them, how many of you would be willing to use that on yourself when you may be in that situation? A lot more people put their hands down, right? So again, it gets to the question in terms of our own interpretation of risk may be very different than those who may be subjected to that. And so I think in balancing that, if you have more trust in terms of how the data may be used, and for whose interpretation of benefits, that may be more helpful. Otherwise, I think that we may be once again subjecting people mainly because of their age and the inferred ability to care for their own good in how we are making these determinations. And that may be, again, more paternalistic and imposing more power on people solely or mainly based on our interpretation of how much risk they should be allowed to take.
Dr. Ho, I want to thank you for such a great presentation that generated a lot of discussions. And I know folks have more questions, but we're running out of time. Just to remind everybody, our next webinar is March 13th at noon Eastern Time with Dr. Michalowski from the University of Minnesota, talking about leveraging clinical decision support systems to address multimorbidity in aging populations, advancing AI for better care management. Also, our webinar sessions are uploaded on our YouTube channel about 5 or 6 days after, so you can also catch the recording there. And again, Dr. Ho, thank you so much for joining us today.
Thank you.